So this study was a study of Nivo monotherapy followed by Nivo-Ipi boost in patients who progressed or had stable disease at 2 years in treatment-naive patients with metastatic clear cell kidney cancer. And we hope to show what the activity of Nivo monotherapy was in this population and what the contribution of a Nivo-Ipi boost to those who didn't respond. And we published the clinical results of this study, which I presented the final results at ASCO GU last year. We published them in the Journal of Clinical Oncology in April of this past year. And this presentation at GU ASCO was to emphasize one of the correlative endpoints, which was to look at treatment-free survival in the patient population, particularly the clear cell kidney cancer patient population on this study. Nivolumab was the first anti-PD-1 approved, but it was approved in the second-line setting for patients who progressed after single-agent TKIs. And since we don't really give single-agent TKIs to patients in the front line anymore, there's not much opportunity to use Nivolumab as a single agent in the second line. The data in the second line in the 025 study was not felt to be sufficient to go against sunitinib in the front line. And so BMS, when they designed that study, looked at the combination Nivo-Ipi versus sunitinib and never looked at Nivolumab monotherapy. So this study was a chance to actually tease out the components of that combination. So Nivo is not really used at all in kidney cancer except as part of studies. Treatment-free survival is a property of immune therapy, in contrast to what we might see with chemotherapy or TKI therapy, where patients progress on treatment and then need to go to another treatment, or if you have to stop treatment, the disease progresses. So there's very little treatment-free survival outside of immune therapy, except maybe for surgery. But immune therapy has the property of having tumor control persist after treatment stops. And we feel that that's a real important value of immunotherapy, something that patients want, which is to have their treatment stop, but the control of their disease persist. And we think looking at the ability of regimens to do that adds value to understanding the impact of those regimens from a patient perspective. And so that's why we've looked at it in the past in the 214 study in kidney cancer on both the Nivo-Ipi and sunitinib arm, and in studies of immunotherapy in melanoma, and have shown that those studies produced significant treatment-free survival, but they were all handicapped by the fact that there was no defined treatment endpoint in those studies, while the HCRN study had the benefit of having treatment stop by and large at 96 weeks or at the time of progression or toxicity. So this is, I think, the provocative part of this data, and it comes from the results of the clinical trial. There's been this general perception that I think is misguided, that patients with favorable risk do not respond to immune therapy. And that's based on, I think, the results of the 214 trial, where those patients with favorable risks tended to do better early on with sunitinib than with Nivo-Ipi. And that's why Nivo-Ipi was not approved in the favorable risk. But I've been in this business for a while, and we gave high-dose IL-2 immune therapy to patients going back 30 plus years. And the favorable risk patients, as we now define them, were the people who did best with immune therapy. And so I always questioned that particular result. And really the result is that favorable risk patients do better with sunitinib than the poor, intermediate, and poor risk patients. But immunotherapy patients, it really doesn't really matter what their risk is with regard to how they do. And I think we've shown in the HCRN study that favorable risk patients can have considerable response to just Nivo monotherapy with 58% response in Part A and Part B combined, and that response is meaningful with those responses persisting and even after treatment stops, creating considerable treatment-free survival, and that those patients, a large percentage of their time, 99% of the 36 months, is spent alive. It doesn't mean that Nivo is better than Nivo-Ipi in the favorable risk patients. It just means that immunotherapy works in the favorable risk patients and should be considered as an option. Well, I think a lot of physicians who understand what's going on with immunotherapy are starting to use Nivo-Ipi in their favorable risk patients when insurance will approve it. I'm not sure what it's going to take to get regulatory approval for a pure immunotherapy regimen in the front line, but it's something that I think is worth pursuing because the treatment options, the doublets that are approved in the favorable risk population have much more toxicity than Nivo-Ipi, don't produce treatment-free survival, and have survival ratios, hazard ratios compared to sunitinib greater than 1. So they represent poor options for patients, while a regimen that can potentially produce a durable response even after treatment stops is certainly something that patients would want.